Hi, my name is Jolene McLeod. I'm a registered social worker and the clinical team leader for the Sask North Acquired Brain Injury Outreach Team, which is part of the Acquired Brain Injury Partnership Project in Saskatchewan. In this module of the Introduction to ABI, I will be talking to you about substance abuse and brain injury. Acquired brain injury and substance use, both alcohol and drugs, often go hand in hand. People who abuse drugs and alcohol have a higher incidence of sustaining an acquired brain injury from falling or driving while intoxicated, for example. Furthermore, the effects of alcohol and drugs only get worse for people after an acquired brain injury. Approximately 1/3 of acquired brain injury survivors have a history of substance abuse prior to their injury, and alcohol and other drugs are directly involved in more than 1/3 of incidents that cause acquired brain injury. Also, 20% of people who do not have a substance abuse problem before become vulnerable to substance abuse after their acquired brain injury. This is why it is important to discuss with your clients that it is recommended that they don't use alcohol or drugs after their injury. Individuals who have sustained an ABI face numerous obstacles on the road to recovery, and some turn to alcohol and drugs to cope with these obstacles. That is why it is important to talk with your clients about the adverse effects substance use can have on a healing brain. The following slides contain information on what to review with your clients when discussing substance use and some strategies that can be used for addressing substance use with individuals who have an ABI. These next few slides will examine the relationship between substance use and abuse and acquired brain injury. Substance use and abuse increases risk-taking behaviors that are associated with sustaining an ABI. For example, drinking and driving, riding with an intoxicated driver, violence, and so on. Substance abuse increases the probability of being involved in a motor vehicle accident, and it also increases the probability of sustaining an ABI due to a fall. Substance use and abuse may also affect the course and consequences of the ABI. Intoxication at the time of injury may mask an ABI due to similar symptoms, for example, an unsteady gait, confusion, etc., which in turn would delay appropriate diagnosis and treatment. Individuals with a history of substance use, abuse, and dependence also experience brain changes, which can be compounded by an ABI. Intoxication at the time of an ABI is associated with the need for more intense treatment following the ABI. Also, pre-injury substance abuse is a strong predictor of post-ABI disability and non-productivity. There is no safe amount of alcohol and drug consumption following an ABI, particularly in the first few years of recovery following the injury. Substance use and abuse may complicate issues of ABI recovery by lowering the seizure threshold, increasing risk for additional ABIs, contributing to brain damage, and after an ABI, alcohol and other drugs may have a more powerful effect on the individual. The following ABI-related symptoms may hinder treatment for substance abuse. These include cognitive limitations, increased irritability, problems with inhibition, treatment of pain with medications, and problems with initiation. The negative consequences of ongoing substance use or abuse following an ABI include the interference with the natural healing process of the brain, increased risk for seizures, exacerbations of ABI-related physical and physiological symptoms, for example, balance, depression, etc. magnifications of ABI-related cognitive difficulties, for example, judgment decision-making, increased risk for legal difficulties, difficulties distinguishing whether cognitive issues, for example, memory, are due to the ABI or substance abuse, and increased risk for future ABIs. The adverse effects alcohol and drugs have on a healing brain can be devastating to the quality of life for a person in recovery. After an injury, the brain has to relearn skills by discovering new ways to transmit information. The brain does this by making new connections between neurons to compensate for the part of the brain that was damaged. But using alcohol and drugs slows recovery by interfering with the new connections between neurons, inhibiting the brain's ability to heal and adapt. There are many reasons why clients with this concurring condition fall through the cracks. A few of those reasons include: providers are trained to identify and treat either brain injury or substance abuse, but not both. The effects of brain injury can be invisible, but they may prevent clients from successfully following a substance abuse program. Clients with concurring conditions often lack insight and may not realize the seriousness of the problem. Symptoms of brain injury and substance abuse can present in similar ways and so may often go unidentified. Clients with brain injuries may also lack initiation, the initiation that would be necessary to begin a substance abuse program. There's been very little research about what substance abuse treatment methods do or do not work for individuals who have sustained a brain injury. Most techniques that are used by clinicians can be adapted to be effective for individuals with a brain injury. However, sometimes special considerations and/or adaptations need to be made to make the treatment more useful and effective. The following slides will examine motivational interventions, which are also known as motivational enhancement techniques. This is one method that has been shown to be effective for individuals with an acquired brain injury. Motivational interventions can be used to help individuals become ready to participate in treatment. Motivational enhancement techniques have been shown to have a positive impact on participation in substance abuse treatment. However, it is important to note that motivational techniques must be matched to the person's stage of change. The Stages of Change model was developed by James Prochaska and Carlos Di Clemente. It describes how ready a person is to address problems related to their alcohol and/or drug use. It's important to note that motivational interventions have many strengths for individuals with an acquired brain injury. They encourage clients to understand the discrepancy between their goals and their behavior, and they can also help the individual find post-injury sources of accomplishment and pleasure that compete with the satisfaction of substance use. The following slides will examine this model. The first stage in the Stages of Change model is pre-contemplation. In this stage, the individual is not considering making a change. The individual needs information linking their problems and potential problems with their substance use and education about negative consequences of substance use. Treatment suggestions for this stage include establishing rapport, building trust, provide education, raise doubts and concern in the individual about their substance using patterns, and explore their perception of a substance use problem. Education could include the dangers of substance use after a brain injury, specifically focusing on no use. You can also discuss the problems in a general way to be less intrusive to the client. For example, you could pose the question, what would have to happen to you to show you that you had a problem with substances? The second stage of change in the Stages of Change model is contemplation. The individual is aware of some pros and cons of substance use, but feels ambivalent about change. Interventions at this stage might seek to explore these feelings of ambivalence and the individual's awareness of the negative consequences of continued use and benefits of decreasing use. Treatment suggestions include helping the individual to tip the decisional balance scales toward change, and elicit self-motivational statements of intent and commitment to change from the individual. It might also be helpful to have your client sit down with you and weigh the pros and cons of using and of not using. The third stage is preparation. At this stage, the individual has decided to make a change and begins taking steps toward recovery. Interventions at this stage include strengthening commitment to change and planning for which method of treatment will best fit the individual. For example, inpatient, outpatient, etc. Treatment suggestions include offering a variety of options for treatment to the individual and helping them develop a treatment plan and supporting self-efficacy. The fourth stage is the action stage. This stage involves the first active steps toward making change. The individual requires help in executing the action plan and working on skills to maintain their recovery. Treatment suggestions include engaging the individual in treatment and reinforcing the importance of recovery. Help them identify high-risk situations and coping strategies to overcome those situations, and always be a source of encouragement and support. The fifth stage is the maintenance stage. In this stage, the individual establishes new behaviors on a regular basis. Interventions at this stage are providing the individual with relapse prevention and assisting with maintenance plans. Treatment suggestions include helping the individual identify healthy, positive leisure activities that are alcohol and drug-free. Help the individual practice new coping strategies and maintain supportive contact with the individual. Relapse can also be part of the stages of change model. Assist the individual to re-enter the change cycle and explore the relapse as a learning opportunity. Explore what can be learned from the relapse. It is important to realize that relapse is part of the process, and you need to help prepare your clients for these lapses so that they can learn to manage situations and learn from these setbacks. Common areas for skill building that may assist you and your client in their treatment plans are things like communication skills, anger management, relaxation training, coping with grief, coping with boredom, problem solving, building healthy relationships, and so on. These next few slides will include some practical tips for addiction counselors on how clients with brain injuries may present in an addictions program. So they may miss sessions, not identify with the group, misinformation, misunderstand what's said and fall behind. They may ask about material that's already been covered. They may talk too much or go off on a tangent. They may have difficulty keeping up with conversation. And they may have poor follow-through on homework assignments. They may get stuck on one word or topic, be unable to remember new information, although their historical memory is good. They may not be able to pick up on social cues, or they may make socially inappropriate remarks. They also could become easily frustrated, irritable, impatient, and overly emotional. Tips on how to modify your approach include slowing down in sessions, simplify your language, offer small bits of information instead of large amounts, give the client extra time, encourage note-taking or hand out printed copies, anticipate a higher frequency of off-topic remarks. Repeat information using short, simple phrases. Redirect clients when they are off topic, talking excessively, or behaving inappropriately. Keep instructions brief and clear, and get feedback by asking, for example, "Do you understand?" And summarize the ideas and points. Things to keep in mind include: clients may lack insight as a result of the injury and may not recognize his or her cognitive deficits. Avoid confrontation over inappropriate behaviors. This will only escalate the situation. Instead, redirect the client and roll with resistance. Be flexible, but make clear what is acceptable. Don't assume that non-compliance arises from a lack of motivation or resistance. Always check it out with your client. Consult with ABI staff about how to tailor treatment to the client's learning style, and remain in contact to monitor progress and make changes. Practical tips for ABI workers include educating ABI clients and family members about the risks of using substances. Involve family and social networks in supporting the client to address the issue. Take a history of the client's past and current substance use. Ask what effect substance use is having on your client's life. Assess the stressors and risk factors that might cause clients to begin using. So, for example, boredom if they have nothing to do, or social isolation, depression, etc. And help the clients find meaningful substance-free activities. And most important, establish ongoing contact with addiction professionals to exchange information and ensure that the client gets appropriate treatment. There are 8 tips for integrated treatment. Goals should be interwoven, not sequential or parallel. Treatment should be holistic, addressing lifestyle, not just substance use. Both the survivor and clinician need to collaborate to develop a mutually agreed upon treatment plan. Clinicians should help the survivor to develop awareness and optimism so that their motivation for recovery can be internalized. Different services will be helpful at different points in recovery. Treatment is long-term. Staff should be cross-trained to work with both ABI and substance abuse. Staff should be experienced and have smaller caseloads. When working with individuals with an acquired brain injury, it is important to remember that some clients may never fully grasp the scope of their problems as we would like them to, but they still can make progress, and this is important to keep in mind. There really is a catch-22 problem for individuals with an ABI and substance abuse. Service providers are rarely trained to address both issues. Individuals often don't fit into substance abuse programs. There may be a high likelihood of crisis problems, but a poor fit with crisis service providers. There also may be a poor fit with traditional support programs such as AA or NA. Oftentimes, too, there are few supports for both caregivers and the survivors, or a loss of peer group membership. Cognitive impairments may affect a person's learning style, which makes participation more difficult. Misinterpretation of memory problems as resistance to treatment can undermine the therapeutic relationship. Behaviors may be interpreted as disruptive, particularly when the individual shows no visible signs of a disability, which is very common. Alcohol and drugs can seriously interfere with recovery after an acquired brain injury. Educating family members and the clients you are working with about the effects of alcohol and other drugs is a very important task for all members of the rehab team. There are numerous resources available that will assist you with this task. The following slides contain some commonly used sites that have resources that will be helpful to you in the process of educating your clients and family members. The Ohio Valley Center for Brain Injury Prevention and Rehabilitation of Substance Abuse Treatment and Brain Injury is a very good resource. The website offers a variety of information and educational resources for professionals, family members, and survivors about substance abuse and brain injury. Resources and pamphlets are available for purchase, as well as the Substance Abuse and Brain Injury Toolbox. Also, a lot of their resources can be printed directly off the website below. The abuse screening tool looks at amount, background, use, social, and environment. The tool was designed to be used by non-substance abuse professionals to use as a guide to help frame questions and identify responses that may indicate a substance abuse problem. You might find using this tool helpful in the intake process. A PDF version of this tool is available for printing at the website below, and the next slide will give an example of what the tool looks like. The Substance Abuse and Brain Injury Project was initiated to study the problem of substance abuse and brain injury. The goal of this project was to facilitate ongoing interdisciplinary management of clients living with both acquired brain injury and problematic substance use. The project developed a manual to be used both by substance abuse and brain injury providers and a client workbook that can be used by clients, with or without their providers, to help manage co-occurring conditions. The client workbook is available for download at the website listed here, and I have a copy of it on the next slide as well. The provider manual is available by registering at the website, and there is a cost of $25 for this manual. This slide shows a copy of what the client workbook looks like. The workbook was designed by a partnership between Community Head Injury Resource Services of Toronto and the Centre for Addiction and Mental Health. It is broken down into sections, and as mentioned before, it can be used both with or without the service provider for the client to work through. Lash & Associates Publishing. There are numerous resources available on this website for acquired brain injury. Tip cards, as shown on the left, for substance abuse after brain injury are among some of these many resources available for purchase. The website listed below is where you can go to access many more resources and publications that Lash & Associates has available. The Brain Injury Association of America has published this resource booklet called Substance Abuse Issues After Traumatic Brain Injury. The website has a variety of different resources on ABI. When substance use is searched, it will bring up a PDF file of this resource booklet, which was developed for family members, friends, or caregivers of individuals with an ABI. However, it can also be very useful as a resource for professionals working in the community. Thank you for listening to my presentation. I hope that it has given you an understanding of the issues around substance abuse and brain injury.